Brian, I want to tell you a quick story. I actually sat on a plane going out to speak at Parker, Vegas in January, and sitting next to me was Tiger Woods' coach, Butch Harmon. And what he said, I asked him, I said, what do you think the biggest problem is in golf? And he said, it's the first 6 inches. And I said, what do you mean the first 6 inches? He goes, it's the first 6 inches of your takeaway. I said, really? Why is that? He goes, because if you don't take it away correctly, if you hit the ball straight, it's a total mistake. I said, huh. You know what? That makes sense, because in chiropractic it's the same way. If I don't understand exactly what I need to do the first 6 minutes of a patient's case, meaning to set up the treatment plan correctly, if I release them at the right time, it's a mistake. So, obviously, talking to him, it was really funny because we had the same problems in common. We need to start the case off correctly by setting up particular goals that we need. If we don't, then how do we know when to end the case? And that just falls right into what the problems are within a documentation system. If we don't set the cases up correctly, we don't know when to release them. We don't know when to release them. We end up treating the patient for longer than we need to or shorter than we need to and never really getting the maximum benefit for the patient. So it's just an interesting story. I thought it fit perfectly. So
yeah, that's cool.
As we look at the definition, this is the one thing that I always get from people. Well, John, what's the definition of medical necessity? I go, well, has anyone ever seen it? And I get, no, I've never seen it before. It's almost like the blind leading the blind. I don't know where it is or anything else. So what I found was that most people have never seen a slide before on what is medical necessity itself. So I decided to actually put it together, and I just pulled it down directly from Medicare. It's almost like the Easter Bunny. No one's ever seen one, but we've all heard of one. No one's ever seen a rabbit lay eggs, but we all have to deal with it every now and then. So what I found was that the definition directly from Medicare is this. The patient must have a significant health problem in the form of a neuromusculoskeletal condition necessitating treatment, and the manipulative services rendered must have a direct therapeutic relationship to the patient's condition and provide reasonable expectation of recovery or improvement of function. Now, if we look at this, it makes it real simple to figure out what we need at the beginning of a case. We need a diagnosis that is neuromusculoskeletal, and it must show direct relationship all the way to the treatment and over to the outcome, and the outcome must be functional. It must be measurable and functional. It can't be explained any more simple than that. And it's easy if we create a good treatment plan. At the end, I'm going to show you exactly what you should be thinking for that. And, thank God we have a decent system to be able to do it with. But it's important to understand this definition because this is what's required in order to be able to start the first 6 inches of your swing or beginning to start the case correctly to be able to show medical necessity and also be able to show when to get out of the case. So going forward, we have to look at what the findings were, and this will make a little bit more sense now because now we can see what the issues are. In this 2005 OIG study, the one I did before, they found that the most average problem was showing medical necessity between the 13th and the 24th visit, which means that we were not being able to show medical necessity after 24th visit. 100% of the claims after 24 were not necessary. That goes back to what I said before. If you look at doctors who don't understand medical necessity and don't understand documentation and never do treatment plans correctly, it would make sense that all of them can't show necessity after 24 visits. But if you could do it correctly, it was easier to do so. So what my job is today is to get you to understand what you need to do to set the case up. And we keep going in findings. We look at, now it says in this current report, the beneficiary must experience a recurrence or exacerbation of a previously treated condition that may necessitate treatment, the start of a new treatment episode. That's important. So we need to show when a new episode starts. One reviewer explained because Medicare covers patients that are predominantly 65 or older, the chiropractor is often faced with a chronic or recurring conditions. That's another problem because the definition of maintenance care and chronic care are almost identical. But there's a way out, and I'm going to give you the action step. I'm going to show you exactly what you need to do. So obviously, anything over 24 is a problem. The reason why anything over 24 is a problem is because we have an issue with how we create the case. And if we don't create the case correctly, we end up treating the chronic condition for a long period of time, and it creates this long chain of visits that creates a major problem for ourselves. Now, if we look at what the other findings were, it says in here The expectation of functional improvement can be determined only from a complete medical review of the treatment episode, meaning they had to look at more than just one date of service like we talked about earlier. CERT looks at one date, but now they're looking at a group, and that means that we have to be able to create cases that are more like novels as compared to, let's say, days of our lives. In a case, we need to show the beginning all the way to the end, like a novel does. Even if they're a group of novels together, it's beginning, the end, and then some time off, and then a new novel which picks up the story later. Now, as compared to what most systems are like, meaning there's no differentiation between active care and wellness care, where it's always the same thing over and over and over, and no one can tell where active care ended and wellness care began, and that's a major problem. So we look at the next thing, and what they found was the biggest issue was that we didn't know how to do a treatment plan. Of the 76% of records that reviewers indicated contained some form of a treatment plan, which meant that 24% didn't have one at all. 43% of that 76% didn't have any goals. 17% lacked objective measures, and 15% lacked recommended levels of care, which means that we don't have a clue as a professional on what's going on within treatment plans. Now, I think it's a problem because we have a word issue or our own syntax issue. So if we look at it, we have to figure out why this is the case. Now, one member of the carrier said we often don't get treatment plans for the first visit episode, usually because it's told to the patient and not really documented. And what they found was the general trend is that the patient will be treated for several months, 3 to 4 times per month, and there's no documentation of any treatment plan or any goals. Now, this isn't just one person talking. This is the majority of them talking. So we know it's pervasive within other systems, but there's ways to fix it. In fact, what they found here was that it's not always documented as far as treatment plans, but it's verbal. We're going to try and fix this problem. But remember this, from a review standpoint, if you didn't write it down, you didn't do it. And you need to be able to write this down. In fact, they honestly feel, these carriers feel, and this is the problem, that treatment plans in general have not been adopted or incorporated into our profession. And that's just not true. We just don't know what they're asking for, and I think that once we do, we'll be fine. Now, if we look at it graphically, I call the difference between cases and a case, or the case versus cases. And here's where it starts. A new patient comes in with a complaint. They start at the very beginning. They have a major problem. We start out with this whole issue. If we look at the left side of the graph, that would be percent improvement. Bottom would be over time. So the patient starts in the lower left. The patient starts with a new complaint. And then from there, the next thing that happens is the patient gets better to the point where they reach maximum medical improvement or maximum improvement, whatever you want to call it. Once they reach that level, then they usually have, later on down the road, unless we wrap them in bubble wrap and leave them in the corner, they're going to go out and use themselves or use their bodies or whatever, and they're going to come back with a new issue. Now, the patient returns with this new condition afterwards. And this happens all the time. We see it all the time. The problem is not the fact that the patient returned. Even if it's the same condition, that's not the issue. The issue is that we don't understand, because ChiroSpeak, we call this usually one case. And that's because a case or care plan ends up being, at the very beginning, what the patient needed as far as visits, usually how long and how often, and how much did it cost. And that's usually all it is. And I think that stems from practice management groups really just saying, it's important to handle money because the patients follow the money, blah, blah, blah. But we never really deal with the functional aspect of what a treatment plan is. When do we get out of the case? If we jumped out of a plane, when do I pull the ripcord and let the parachute out? And if we don't know when, we hit the ground at terminal velocity, and that's the problem. So if we look at it from a Medicare standpoint, cases are equal to a case only if we can break them into small pieces. So remember, in chiropractic, we call this entire timeline a case or a case fee or a care plan or something like that. But what is it in Medicare? Well, in Medicare, a case would go from the beginning when they came in to the point where they reached maximum improvement. That would be a case. That's a small piece. And if we played it out into smaller pieces, we'd see it came from, once again, from onset to MMI. That is a case. Now, that would be a small case, and you could have numerous cases over time, not just one. Because one of the things we need to understand is most people will complain, oh, well, John, Medicare's trying to dictate my care and tell me what I can do with patients. No, that's not the case. That's not the issue at all. They don't care how many cases are there, and they don't care how long you treat the patient. They just want to make sure the right person is paying. So if we break this down even more, we can see here that if we had the green or the blue-green would be active care, the yellow would be wellness care as the patient came back in, and then the next thing would be active care. But in order to separate them, we need to know a few things. Obviously, at the beginning of a case, it would be a Box 14 date, meaning the day they came in for that particular problem to our office. That makes sense. Everyone knows that one. And once again, that's a good thing that billing precision will track for you. It's great. But the one thing we don't do that separates out an active care case from a wellness care case is what's called a discharge summary. Now, a discharge summary is like at the end of the book. We know that the beginning of the book is telling the story. We know it's the whole story through the middle of the book. And then at the end, we say the last two words, the end. And we know at that point in time there's no more pages to flip. The book's over, we move on. But unfortunately, in most handwritten notes or dictated notes, we don't ever say this is the end of the case. So you have to have an action step. This is it. This is what you say. You need an action step that asks these 4 questions at the end of your case. A, what goals were achieved? B, what goals were not achieved? C, why was the patient released? And D, are there any further recommendations for care? Now, it would be simple to put this in your note when you say, okay, what goals were achieved? The patient reached their goals of being able to walk up 10 flights of stairs. Okay, what goals were not achieved? Well, the goals that were not achieved were, full range of motion because the patient has major arthritis. Why was the patient released? Because they reached MMI. And the last part was further recommendations for care. Patient accepted wellness care will return every 2 weeks PRN. Boom, done. That is a simple thing to put at the bottom of your note on the last day you see them, when you go to release them from active care into wellness care. Boom, done. Everyone knows that's the end. And by the way, for a practice tip, that's a great way to tell your staff, hey, listen, when you see a discharge summary note, we know the next time they come in, there's an ABN form that needs to be signed because the patient went from active care into wellness care. So that could be like a timing issue for everyone involved. Makes total sense, makes the game easy. This is how you say the end at the end of the case. Now, if we look at it, we have to know this because within Medicare, there's these things that we're finding that the judges are looking for. Now, when I say judges, I mean administrative law judges. These ALJs do reviews, and after the carriers tell you, no, you don't deserve to get paid, and then the QICs tell you, no, you don't deserve to get paid, to secondary appeals, you can go to, state your case in front of an administrative law judge. That judge will start looking at cases, and what they found is, or what I found is, when listening to the hearings and what the findings are, that these judges are legislating how care should be broken down. And what they're talking about is what's called a 60-day rule. And one of the big things that is a total red flag for the carriers to go ahead and start looking at doctors is how long is the patient under active care when we go from AT into GA. And what they're looking for is the average case being less than 60 days long. Now, that doesn't mean every case must be 60 days or less. What they're looking for is the average, meaning if your first case, when the patient came in with a low back disc, as we see here on the left-hand side, the first part where it's blue-green, we could say, oh, okay, the patient has a major problem. Let's say it's a disc, a lumbar disc. It may be 75, 80 days to get them from their condition where they are now to being stable. The next time they come in, maybe 2 months later, and it'll only be maybe 4 or 5 visits to get them stable again. You add that together, and now we're under 60 days on average for your cases. And that's what they're talking about. They're not talking about being 60 days for one case being a red flag. They're talking about, on average, what are your cases. So they're looking throughout your what's called your total claims universe to come up with this average, not just one case. It's the average case, okay? So be aware. And I think, Brian, you guys have a specific system that handles that, right?